Myself, Dr. Fowzan Firoz, lecturer from the Department of Prosthodontics, Yenepoya Dental College, Yenepoya University. It's my privilege to present today here for you on the topic temporization in FPD. By the end of this presentation, I hope all my students will be able to define provisional restoration. All of you will be able to explain the need for provisional restoration, and all of you will be aware of different techniques to fabricate a provisional restoration. To start with, provisional restorations are also called as temporary restorations. It's also called as transition restorations, also called as treatment restorations, also called as interim restorations. So these are the different synonyms that we use to term the word provisional restoration. Provisional means what? Provisional means temporary. So basically this restoration which we are going to give, the provisional restoration, is only for a temporary basis. Temporization is the process of fabricating a provisional restoration. So today we will be dealing with the temporization process. So what is a provisional restoration? Provisional restorations are a prototype on which functional, occlusal and aesthetic adjustments are made to optimize the definitive prosthesis. So basically a provisional restoration is providing a prototype on which certain functional, occlusal and aesthetic adjustments are made so that you can optimize your final prosthesis. They basically enhance the prognosis of the definitive prosthesis as well as assist in the preparation of the oral cavity for the definitive restoration. So basically it is also assisting a dentist to assess or to plan how a preparation of the tooth should be done to get a good restoration, to get a good definitive restoration. According to GPT-8, provisional restoration is defined as a fixed or a removable prosthesis designed to enhance aesthetics, stabilization and or function for a limited period of time, after which it is to be replaced by a definitive prosthesis. Later it was modified to GPT-9 definition. Temporization is to establish aesthetics, occlusal stability and function for a limited time in preparation for a definitive prosthesis. Also to verify therapeutic outcome and patient acceptance before the definitive prosthesis has been fabricated. So there are certain ideal properties for any restoration, for any restorative material. So for a provisional restoration also there are certain ideal requirements or minimum requirements to be considered as a provisional restoration. The first one, the material chosen must be dimensionally stable. It has to be dimensionally stable. The material should be resistant to functional and occlusal loads. The restoration must be reasonably resistant to fracture and should have sufficient compressive and flexural strength. The restoration margins must be polished, should be tissue friendly and shaped to promote healing and discourage plaque development. This is one of the most important requirements for a temporary restoration. If it is not polishable, if the material is not polishable, if the material cannot be smooth enough, it can lead to plaque accumulation and cause more harm than use for the patient, and also it's more work for the dentist as well. Once there is a lot of plaque accumulation, there are chances of a lot of gingival inflammation, and also the healing of the gingival tissue should be done by the dentist, or there should be some kind of time period for the healing of the gingiva, which will hamper the treatment protocol. The temporization technique should ensure a quick and simple fabrication. The restoration should be aesthetically pleasing. Again, one of the most important point, if the aesthetics is not achieved with this temporary restoration, the patient is going to have lack of confidence in your treatment. The patient is going to feel, because once you finish your tooth preparation, once you give your provisional restoration, the patient is going back home with the provisional restoration. And if the provisional restoration is not good enough, the patient will have a feeling that the final restoration will not be so aesthetic as the patient wants it to be. So it is necessary that it has to match, the shade has to match with the adjacent tooth, at least close to the shade which is for the adjacent tooth. It should be odorless and non-irritating, and it should be compatible with luting cements. So why do we need a provisional restoration? Is it necessary that we have to give a provisional restoration after a tooth preparation, be it for a fixed partial denture or be it for a crown? Is it necessary that we have to give a provisional restoration? And I would say yes, absolutely. It is absolutely necessary to give a provisional restoration to the patient after tooth preparation is done. The first point, the first reason being the comfort. The patient will always be comforted if you give that a provisional restoration rather than just leaving the patient after the preparation. Once the preparation is done, be it your anterior teeth or be it your posterior teeth, if there is no tooth replacing, the patient goes back and tries to do his normal functions, there will be some amount of discomfort for the patient. So to get back the comfort of the patient, it is absolutely necessary to go for a provisional restoration. Coming to occlusion and positional stability, it is always necessary to maintain the occlusion even for 4 or 5 days, which is required to fabricate a definitive prosthesis. Even for those 4 or 5 days, it is necessary to regain back the patient's occlusion and positional stability. Why? Once the preparation is done, there are chances that the adjacent tooth can move into the area of the prepared tooth, since there is a loss of contact. So once there is a loss of contact, there is a chance that the tooth will move towards, the adjacent tooth can move towards the prepared tooth. Also, the opposing teeth, which is in occlusion, can also come occlusally, can move occlusally and cause supraeruption on the opposing teeth and cause the reduction of space in the restorative area. So it is necessary that you give a provisional restoration to the patient to maintain the occlusion and positional stability. Then comes to function, or the most important reason why you have to give the provisional restoration is to regain the function. Let's say we are preparing a 3-unit FPD on one side of the arch. Let's say you're preparing 1/6, 1/5, you're preparing 1/5 and 1/7 to replace 1/6. So here basically all the 3 main posterior teeth are not fit for its function. So in such a situation, the patient will surely have some amount of discomfort, and this will lead to patient dissatisfaction or lack of confidence in the patient about the treatment. Also, it is always necessary to maintain that tooth in the same manner. There are chances that once the preparation is done, there are chances that the tooth can even fracture when the patient is eating or patient is doing their normal functions. Sometimes the patient really don't think about what they eat. So if it is a hard material or something which is some hard food, the patient tries to chew on it, there is a chances that your tooth can even break. The prepared tooth can even break, and obviously you will be losing an abutment also. So it is always necessary to protect the tooth and also to provide function, a proper function for the patient. It is necessary to provide a provisional restoration. Coming to gingival health and contour. The provisional restoration helps in maintaining the contour of the gingiva. So once the preparation is done, for example, let's take the anterior tooth. When you're doing an anterior tooth preparation, we are mostly giving it equigingival or we are giving it subgingival. So in such situations, there are chances that the gingiva can collapse onto the tooth. So to maintain the contour, it is very necessary to give the provisional restoration. If you do not maintain the contour, if the gingiva is collapsing, then when we are doing a cementation, it is always inherent that you will have to prepare the gingiva again. You will have to cut out the gingiva again, and you will not get a desired aesthetics after the final cementation. Then comes to aesthetics. As we all know, when an anterior tooth is prepared, it is impossible, especially in the present age, it is impossible that the patient will be happy to go around with the prepared tooth in the anterior region. So it is always necessary to regain back the aesthetics, to regain back the patient's confidence, and also to get an understanding of the final aesthetics which can be maintained in the patient. For the dentist, it is very important that you need to provisionalize the preparation. What are the requirements for a provisionalization? So once you do a provisionalization, what is the function of this provisional material or this provisional restoration? What does it do? It is basically having biological, mechanical and aesthetic requirements. Coming to the biological requirement, the first requirement is the pulp protection. When you're doing a restoration on a vital tooth, or when you're using a vital tooth as an abutment, it is very necessary to protect the pulp to avoid any post-operative sensitivity. So a provisional restoration must seal and insulate the prepared tooth surface from the oral environment to prevent any kind of sensitivity or further irritation of the pulp. Coming to the next biological point is your periodontal health. As I was speaking earlier, to facilitate proper plaque removal, and a provisional restoration must have a good marginal fit, a proper contour and a smooth surface. So to maintain a good periodontal health, it is necessary to have a good marginal fit. It should have good contour and also should have a smooth surface so that there are no plaque accumulation occurring. Coming to occlusal compatibility and tooth position, I was speaking the same point earlier. The provisional restoration should establish or maintain proper contact with the adjacent and opposing teeth. Inadequate contacts allow supra-eruption and horizontal movement of the adjacent tooth. Prevention of enamel fracture. So there are certain situations where when it comes to your veneers, where you expose the finish lines, the enamel on the finish lines. So there are chances that enamel can fracture while having some kind of food or while chewing some kind of hard food. So in such situations, it is necessary that you protect these kind of finish lines. So provisional restoration should protect the crown preparation margins. This is particularly true when you are doing partial coverage designs, in which the margin is very close to the occlusal surface of the tooth and could damage during mastication. Now coming to the mechanical requirements. Those were the biological requirements. Now coming to the mechanical requirements. So the first mechanical requirement is your function. As I was discussing earlier again, the greatest stresses in a provisional restoration are likely to occur during chewing. A good compressive strength and flexural strength is required to withstand such forces. So the material should have good compressive strength, should have a good flexural strength to take up any occlusal loads while chewing. Retention and stability. A close adaptation of the provisional restoration to the prepared tooth surface is required to prevent displacement and decementation. So basically, your material should have good bonding with the provisional restoration or the provisional cement and the tooth preparation. Then comes your aesthetic requirement. We have finished the biological requirements, we have finished the mechanical requirements. Now coming to the aesthetic requirements. As we all know, how important is aesthetics for any patient in everyday life. The appearance of provisional restoration is particularly important for your incisors, your canines, and sometimes the premolars as well. Although it may not be possible to duplicate exactly the appearance of an unrestored natural tooth, the tooth contour, color, translucency and texture are essential attributes. So when you are replacing, maybe the color might not be exactly the same, but at least the tooth contour and the translucency and the texture should be attributed to the patient. Now let's go into a case which had come to my clinic. Here you can see the pre-op of the patient. Here had come with a fractured tooth. Root canal treatment was done for this patient, this particular patient, and the preparation of the teeth were done. A provisional was fabricated using indirect technique, and the provisionals were polished and the provisionals were finally cemented. So you can see from these pictures that when you see the picture number 1, the patient has come to me with a lot of lack of confidence, with a lot of despair, with a lot of sadness, saying that his anterior tooth has fractured and now he wants to do some replacement. The same day after finishing the root canal, on the same day of the preparation, after preparing the tooth, as you can see in the picture number 2, I am fabricating and sending the patient on the same day with this provisional cemented. This will obviously improve the confidence of the patient. Also, for the dentist can assess the amount of preparation that had to be done. I can also see how well it looks for the patient, how aesthetic it is for the patient. So that is the importance of having a provisional restoration after you prepare a tooth. Now coming to the different materials used to fabricate your provisional restoration. Basically there are two types of materials. You have your resin material and you have your metal based temporization material. Nowadays metal based temporization materials are not so commonly used. Very rarely when it comes to pedo patients, or when it comes to some old patients, when they can't wait too much for it, or in very rare situations we use metal based temporary material. The most commonly used is your PMMA. You have your that is your polymethyl methacrylate, you have your polyethyl methacrylate, you have polyvinyl ethyl methacrylate, and you have your bisacrylic composite resins. I I would always suggest to use a bisacrylic composite resin, because I personally felt that it was a very good material to be used as a provisional restoration. Even in the previous slide which you saw in the patient, there is also a bisacrylic composite resin. Now coming to the different techniques for temporization. As I was saying, temporization is the process of fabricating a temporary material. So we have three methods to do it. We have a direct method, we have an indirect method, and we have a direct-indirect method, which is also called as your hybrid technique. So coming to the direct technique, the direct method uses a prefabricated matrix or a custom impression matrix which is taken before the tooth is prepared on the patient. So once the tooth preparation is complete, the matrix is filled with the temporization material and placed back into the patient's mouth to get the temporary restoration. So what you have to remember in your direct technique is that this is completely done in the clinic. It is completely done on the patient. The matrix, the prefabricated matrix is made in the patient, and also the material is filled into the prefabricated matrix and placed in the patient's mouth itself. So it is completely on the patient. Coming to the indirect technique, in the indirect technique you are basically taking a primary impression of the patient and you are pouring a cast on top of it, and on the cast you are doing a wax up, or you're using the tooth itself to fabricate a silicone putty index. The putty index is made on the cast, not on the patient like in your direct technique. So after the tooth preparation is done, the impression of the arch is taken and the stone model is poured, and the fabrication of the temporary restoration is done on the cast itself. Once the temporary restoration is fabricated, it is taken from the cast and then just cemented onto the patient. No work is done on the patient here. So that is the difference between your direct and your indirect technique. When it comes to your direct-indirect technique, here we are doing some procedures on the patient and some procedures in the laboratory. That is why it is called as direct-indirect technique. So in the hybrid technique, a pre-op laboratory fabricated matrix is constructed and used for chairside fabrication of the restoration. So basically you are taking an impression of the patient, a primary impression or diagnostic impression, doing a wax up, and then rest of the procedure is the putty index is made on the putty index, or the index is made on the cast, and rest of the procedure is done on the patient's mouth. This is called as your direct-indirect technique. So as you can see, the difference between the three: for a direct technique, impression and a cast is not required. So as you can think about it, it is the fastest method. You can finish your fabrication as quick as possible in your direct method, because you are not taking any impression and there is no waiting time for setting of your cast. In the indirect and the direct-indirect technique, you are taking an impression, you are taking a diagnostic impression and pouring the cast, and you are working on the cast, so it takes some more time. In the direct technique, the putty index is made inside the mouth. In the indirect and in the direct-indirect, the putty index is made on the cast. So once the tooth preparation is done in all the three materials, in all the three techniques, in the direct technique, the temporary material is injected in the putty matrix and placed directly in the prepared tooth in the mouth. In the case of an indirect technique, the temporary material is injected in the putty index and placed on the cast. In the direct-indirect technique, again the temporary material is injected in the putty index and placed in the prepared tooth in the patient's mouth. So this is the difference between all three. I hope you have understood these techniques. I will be playing a small video regarding the direct technique. As you can see, the putty is being mixed. Here the typhodont refers to your patient's mouth. So the putty index is made before the preparation. This is your direct technique. So before the preparation is made, the putty index is made in the patient's mouth. And the putty, once the putty index is set, you are cutting out the unwanted areas. You will only require the tooth of interest, that is your prepared tooth, and the two adjacent teeth. Rest of the tooth is completely cut off. So once the putty index is ready, you will go ahead with the fabrication of the provisionals on the teeth. Once the preparation is done, some separating media is applied here. Since this is applied just because it is on the typhodont, on the patient it is not necessary to apply this separating media. So as I was saying, the material of interest is a bisacrylic resin material. So after the preparation, the bisacrylic resin material is injected into the putty index, which is prepared from the patient's mouth. It's completely injected in such a way that there are no air bubbles present. So after injecting, it is exactly placed in position. So while placing in position, you have to make sure that it is pressed properly, it is compressed properly, and it is placed in position. And also make sure that you don't apply any pressure on the putty index above the prepared tooth. Also, you can see some excess oozing out of the putty material. Make sure that you remove any excess which is coming out. You wait for around 2 to 3 minutes. So once you finish around 2 to 3 minutes, the material is has finished its initial set. So once the initial set is complete, you're supposed to remove the putty index. So when you're removing the putty index, make sure that you remove the putty index from the buccal to the lingual. From the buccal direction to the lingual direction. Why not straight occlusally? Because this can lead to dislodgement of the crown from the prepared tooth. We don't want that. We don't want the temporary material to come out, or the temporary restoration to come out from the. Why? Because it takes at least 5 minutes to completely set. There can be some kind of dimensional changes if it comes along with the putty. So it is always important that you keep the restoration on the tooth itself. So after around 5 minutes, you can take it out. Again, I am stressing it out again. The putty index must be removed from buccal to lingual so that the provisional restoration stays. The provisional restoration is removed only after 5 minutes so that we avoid any kind of dimensional changes. After the provisional restoration is removed, the next step is to trim the provisional restoration. You have to make sure where the margins are. You have to locate the margins of the tooth of the preparation, and then you mark those margins, and then you trim out the excess. From here you have to notice certain things. Okay, there are certain precautions while trimming the provisionals. As you saw earlier, the tooth has to be always held from the tissue direction, from the other side, not from the occlusal surface. While during the trimming is done, it should always be viewed from the finish line side, not from the occlusal surface. Also, when you are trimming, you will never remove from the marginal surfaces. Also, you will never trim from the occlusal, means from the axial surfaces of the tooth as well. Always remember, you angulate the burr in such a way that you remove only the excess from the margins. Now, the next, after trimming the excess, the next step will be adjustment of the occlusion. You are using a shim stock foil and the articulating paper for this purpose. A shim stock foil should always be used between the occluding surface of the unprepared tooth, not the prepared tooth, the tooth which is adjacent to it. Okay, not on the prepared tooth. As you can see, after the preparation, you can see without the provisional restoration, when you are using the shim stock on the adjacent tooth, you can see that the shim stock doesn't come out, it stays there. That is because there is proper occlusal contact. Since there is proper occlusal contact on the adjacent tooth, the shim stock will not come out easily. Now, after placing the provisional restoration, when you see the place, once you place the shim stock, you can see that shim stock foil is easily coming out from the adjacent tooth. This means that there is no proper occlusal contact, which also infers that there is some amount of high points which is present in your provisional restoration. So we are placing an articulating paper. After placing the articulating paper, we are seeing where the high points are. We are locating where the high points are. Once the high points are located, we are going to trim down onto those areas. Once trimming down is done, we will again recheck with the shim stock on the adjacent tooth. You can see that the foil is not coming. It means that there is proper occlusal contact. This is how you check for your occlusal contacts. Once that is done, the next step will be your polishing. Once the trimming is done, once the occlusion is retained, the next step is to do the finishing and polishing on the provisional tooth. Here you can see we are just like how the normal acrylic resin is being polished. You are using a pumice and a buff to do the polishing. As I was saying, this is a very important step to avoid any kind of plaque accumulation on the tooth. I hope that video was informative for you. Now, coming to the cementation, after once the provisional restoration is ready, the next step is the cementation. So we have different cements which have been used in the past few years. We have zinc oxide eugenol, which was used recently. We have reinforced zinc oxide eugenol. The liquid can be ethoxybenzoic acid to making it a stronger cement than your zinc oxide eugenol. Then we had the latest one, that is called as your non-eugenol cements, or also called as your zinc oxide cements, which does not have any amount of eugenol, and instead of eugenol they have carboxylic acids which in place. So according to me, if I'm using a bisacrylic resin material as my temporary restoration material, I am going to use a non-eugenol cement, because I always felt that it is very easy, it is least irritant to the patient, it is very easy to remove, to de-cement the provisional restoration once we have to place the permanent restoration. So these are my references. Thank you for your patient listening.